Whether it's wide complex tachycardia or any other arrhythmia, again, go out there and be prepared not just to treat VTAC, not just to treat a flutter, not just to treat SVT. Go out there and be ready to manage arrhythmias without knowing exactly what they are. Because if you're counting on knowing what everything is, you're going to end up uncomfortable.
When I was in paramedic school, our EKG interpretation was taught by an older physician. He had been a doctor in a level 1 trauma center for longer than I had been alive. He'd seen it all, twice. His crisp silver hair and golf course attire put off an air that he could effortlessly care for any patient. We never questioned his stated goal to ensure we all knew how to interpret an EKG and no one got a free pass. An EKG would appear on the screen and he would point to someone with a yardstick. That student went through the EKG with no help from anyone else in class. Nervous, they would go systematically through the process he taught us.
You on 8? You on 8? Okay, you're clear. Stand by for your base.
Welcome to EMS Cast, where we provide high-level education for you, the providers on the streets. I'm your host, Ross Orpit. I'm a practicing emergency physician and EMS doc in Southwest Colorado.
And I'm Will Berry. I am a critical care and flight paramedic in North Carolina.
For those of you new to the show, we dive deep into topics and go deeper than you learn them in paramedic school. However, it's important we always connect these back to a set of guiding principles so that you do not lose sight of the forest through the trees. And today we're going to be talking about wide complex tachycardia, which on the surface may initially sound simple, but it's much more complex than we like to admit. That being said, we're going to give you a set of principles. We're going to give you an algorithm and a stepwise approach to approach these patients so that you can do so in an effective and safe manner. And to help us do this is going to be our guest today, Dr. Kevin Butler. But before I welcome Dr. Butler, I want to give a big thank you to today's sponsor, the Recess Tailor. And I'm thrilled to be partnering with them because they understand this vital concept. Design can improve outcomes. When you're asked to provide fast-paced, efficient, and near mistake-free care, you need a bag that has the equipment thoughtfully laid out such that the right tool is where you need it, when you need it. As Scott Weingart pointed out in our episode on mastering the recess, amateurs talk plans, experts talk logistics. To better understand this philosophy of design improves outcomes, I encourage you to head to the Recess Tailor's website at therecesstailor.com and check out the Scram Bag. The Scram Bag is an airway bag designed to have everything you need for an airway right at your fingertips. Every tool has its place. And it's not just airway bags. There are drug boxes, RSI kits, jump bags, and more. The Recess Tailor will customize any bag to fit your specific needs. So go to the website, click on the contact page, and see if they can design a bag specific to your agency to help you improve outcomes. Dr. Butler, welcome to the show. And first and foremost, why is this topic so important for us to address today?
Thanks for having me. It's great to be here. Wide complex tachycardia is important. It's something that we're all going to see, whether you're a pre-hospital provider, an emergency provider, or even an inpatient physician. Something we all need to be ready to deal with, and it's very time sensitive. Wide complex tachycardia, we always think about ventricular tachycardia, but there are actually other things that can cause it, and they're different causes, and they can be life-threatening in different ways and require different treatments. It's going to be a stressful situation, especially if you have a tenuous patient in a wide complex tachycardia. So I think it's one of those things we need to have an approach that's locked and loaded and ready to treat that patient appropriately before they get any worse.
And having heard you lecture on this topic before, one of the things that really rung true with me is developing some level of comfort in the uncertainty. We most likely will never be 100% certain as to what the etiology of this wide complex tachycardia is, but we need to figure out maybe the most likely cause, and at the very least, a safe approach to treating whatever the cause is.
Absolutely. Completely true for wide complex tachycardia or any other arrhythmia. What I try to teach is kind of almost a two-step approach more generally with arrhythmias. The first step is use all the information that you have. That's the ECG, that's a telemonitor, also the patient's history, the patient's presentation, everything you can to decrease the amount of uncertainty you have about what's going on with that patient. The second part is to treat that patient and manage that patient. And that needs to be done within the scope of uncertainty that still remains. Because even after you go through all that information you have, the ECG, history, exam, you still may not be able to narrow that down to a single cause of what might be going on. And so you need to be ready to initiate treatment that is at the very least safe and hopefully effective for that patient in front of you based on the information that's at your disposal. There's a management principle in the US Marine Corps called the 70% solution, which says that if you have 70% of what you need to execute a plan, that you need to start executing that plan. And I think, 70% is a figure that's picked out of midair, but I think it's a really good philosophy for people in our position to say, yeah, when you're managing an arrhythmia, you may need a plan that's 70% good, and then you need to start executing that plan instead of trying to figure out 100% what is going on.
Okay, so today we're going to go through the steps of how to get to that, 70-ish% certainty and how to start initiating treatment. But if you had to come up with a set of principles for us, if at the end of the day we're like, I have no idea what's going on, what do we fall back on?
So first and foremost, as with everything, the patient stability is the key, right? We're treating the patient, we're not treating the rhythm. You need to be able to trust your clinical judgment, that patient you see in front of you, know when they're sick and not sick. And the second major principle I would just reiterate what Will opened up with, which is fast and wide is VTAC until proven otherwise. Generally speaking, and we'll talk about some exceptions, okay to treat all wide complex tachycardia as VTAC and figure it out on the back end.
So, Dr. Butler, I'm loving this 70% rule. And, sometimes, thriving in an environment with limited information, that sings to the heart of every pre-hospital provider out there. Do you have any guidance? Like, how long are we talking about here? Like, sometimes the patient may be tenuous or possibly stable. We're kind of like messing with this in our head. But do you have any guidelines on how long should we sit there pontificating about this patient?
So I really don't think you should spend more than about 30 seconds looking at an ECG and the patient before you decide what is a reasonable approach that I'm going to move forward with.
And so how do we, when you take that 30 seconds, what are you doing in that 30 seconds? How do you start this approach?
Yeah, so basically when I start this approach, the first thing I want to do is rule out some strange, more unusual, life-threatening causes of wide complex tachycardia right out of the gate. Because if we go forward and manage everything as VTAC, there's only a few really bad mistakes we're going to make that way. So let's look for those possible mistakes or those pitfalls right off the top and filter those out.
Okay, before we get to those possible mimics, then I guess maybe we should start with the pathophysiology. Like, what is wide complex tachycardia?
So definition of wide complex is a QRS complex over 120 milliseconds. So that's 3 small boxes on a standard 25 millimeter per second EKG. So if the QRS is more than 120 milliseconds or 3 small boxes wide, that's wide. Fast, technically over 100 beats per minute. Typically with the more concerning arrhythmias that we're talking about, it's usually more like over 120 beats per minute. So we're going to say about 120 beats per minute with a QRS over 120 milliseconds is a wide QRS. Now there's a number of different things that can cause the QRS to be wide. So, and to understand those, let's just do a brief summary of the conduction system in the heart. So the QRS, that represents the amount of time that it takes the ventricles to depolarize. So the first part of the QRS is the moment that the first cells in the ventricles start to depolarize or contract. And then the duration of the QRS is how long it takes from that point until the very last cell in the ventricles has depolarized. That's what the QRS represents. In order for the ventricles to depolarize, there's a signal or an impulse that gets propagated to them. In a normal functioning heart, that signal initially gets propagated through specialized conduction pathways. So this starts with the bundle of His coming out of the AV node. It goes through the right bundle branch and the left bundle branch, and then it terminates in the Purkinje fibers that kind of reach back up around and wrap around the ventricular myocardium. And those conduction fibers transmit that signal very, very quickly. And the purpose of those is to distribute that impulse in a coordinated manner across the entire ventricular myocardium as close to simultaneously as possible. The second way that a signal can propagate through the heart is cell to cell. So this is when one muscle cell in the ventricle depolarizes and all of the cells are adjacent to it. A moment later, they depolarize. This is like the wave in a sports stadium. Anytime one person stands up, the people next to them stand up if they haven't already stood up. And just the same way that wave propagates slowly around the stadium, so this depolarization propagates slowly through the muscle cells in the heart. So, if the QRS represents the total amount of time it takes for the ventricles to depolarize, you can imagine a normal functioning heart, all of that signal gets delivered almost simultaneously across the heart, and then only a little bit of that cell-to-cell conduction has to happen. And so the whole heart depolarizes pretty quickly. There are a number of things that can interfere with that, causing the heart to depolarize more slowly, which results in a wide QRS.
What are the various things that cause that wide complex to occur?
So one thing that can happen that we see every day is a bundle branch block. Everything's functioning normally in the heart except one of those bundle branches, either the right or the left, is cut off. So now, instead of having all of these really rapid fibers delivering that impulse simultaneously all across the heart, they're only delivering it to half the heart. That second half of the heart has to get that slow wave-type depolarization. And because that's slow, it makes the QRS stretch out longer. So that's one thing that can give us a wide QRS, either in a normal rhythm, in a bradycardia, or in a tachycardia.
Question, to back up a second, so it took a little longer for the ventricles to depolarize and then contract. Who cares? Why does this matter, and what type of symptoms would we see if it's doing bad things to the patient?
Generally speaking, a bundle branch block, we don't care about that much, especially if we know that it's old. A bundle branch block in and of itself is something that people live with, their entire lives, rarely causes symptoms, and doesn't generally affect too much how the heart is doing its job. The important part, and we'll see this later in the lecture, the important part of understanding a right bundle branch block and a left bundle branch block is that by recognizing the associated patterns on the ECG, we can begin to distinguish where that beat is coming from. Because remember, in a left bundle branch block and a right bundle branch block, yes, we get a wide QRS complex, but otherwise, that signal is starting where it's supposed to start, usually in the sinus node. It's coming through the AV node. The AV node is doing its job, and then it's coming down to the heart tissues through half of the specialized conduction fibers. So almost everything is working normally. It's good to be able to recognize those patterns of right bundle and left bundle branch block, because by recognizing them, then we can help to distinguish whether that's the only thing that's going wrong, or maybe there's actually something else causing that wide complex tachycardia.
What about, okay, so we talked about bundle branch blocks as being one of the etiologies, and maybe those are less concerning etiologies of wide complexes, although certainly if the patient's tachycardic, we have to think something's wrong. What are the other, maybe more concerning causes of wide complexes?
Something else we talked about, the conduction through the heart starts in these specialized pathways, and then it gets dumped into the ventricular myocardium, and it gets finished in the ventricular myocardium with that slower cell-to-cell conduction. Well, that slow cell-to-cell conduction can be even slower. So now imagine you're doing the wave in a stadium, but it's super cold and nobody's standing up quite as quick. Well, that wave of propagation across the stadium is going to go even slower than it was before. Similarly, if there's something that causes that cell-to-cell conduction within the ventricular heart muscle to be even slower than normal, that'll widen out the QRS as well. And there's a few things that do that. Sodium channel blocking medications. So anything from Benadryl to tricyclic antidepressants can cause, especially if taken in an overdose, can cause those cell-to-cell conductions to slow down even more than they normally do, and that can widen out the QRS. Turns out that hyperkalemia has a very similar effect on the heart muscle cells as sodium channel blockade. And so a patient with severe hyperkalemia can also slow down that transmission from cell to cell and result in a wider QRS. Also, the third category, so first we talked about interruptions of the conduction system like a bundle branch block, then we talked about the cell-to-cell conduction being even slower than normal. The last one would be, what if that impulse doesn't originate in the specialized conduction fibers at all? What if it originates in a ventricular muscle cell? This, again, going back to this analogy, this is that first person who stands up in the stadium trying to start the wave, right? If it originates in a heart muscle cell, the entire ventricular myocardium has to depolarize in the slow fashion. So that's definitely going to cause a wide QRS. Now that could be a random impulse like a premature ventricular contraction that originates just in some random ventricular myocardial cell. That'll cause a wide QRS. That could be a person who has a pacemaker in. Most implantable pacemakers have an electrode that sits in the right ventricle. So it's delivering the impulse directly to a ventricular myocardium cell, and then that needs to do its entire conduction through the slow pathway. It could also be ventricular tachycardia, which originates in the ventricles. So that's why we get a wide complex tachycardia in ventricular tachycardia. The last one, that's a little bit less common, I would say, would be something like WPW, pre-excitation, right? Because that signal may be originating in the normal place, like in the sinus node, but instead of utilizing the specialized conduction fibers, it's sneaking across from the atrium to the ventricle through an abnormal bridge of tissue, and the ventricular depolarization starts wherever that bridge comes across. So it's starting again in that ventricular heart muscle cell and spreading through the slow manner throughout.
So I get that. You explain in WPW, there's maybe a bridge across that's causing this circular pathway of abnormal activity that may be originating or at least propagated quicker through the ventricles. Help me understand why VTAC, suddenly there's a myocyte or cell in the heart in the ventricle that's abnormally conducted.
So the most common cause of VTAC is in a patient who has some history of heart disease, and they have some kind of damage or injury to the ventricular myocardium. And what that results in is you can imagine that there's an area of the heart after a heart attack, or some people have some kind of, cardiomyopathies that result in scar tissue or abnormal tissue building up in the ventricle. Some of that is going to be effectively dead tissue. It doesn't contract, it doesn't conduct, it's just a scar. But intermingled within that scar tissue, there's often some myocyte that's just abnormal. It's been damaged, but it can still maybe contract a little, it can still conduct signals a little, but oftentimes it conducts signals much more slowly than the healthy myocardium that's around it. And you can end up with a little circuit between abnormal, injured myocardium that conducts that signal very slowly, and then that abnormal slow signal finally kicks out of that damaged myocardium and hits a patch of fresh, healthy myocardium that picks up that signal, kicks it off, right? And because it's kicking it off from the ventricles, it's going to spread through the whole ventricle. And by the time it gets back around to that damaged path is no longer refractory. And it picks up that signal, transmits it slowly again, kicks out right at the same spot, and generates another impulse in the ventricles. So it's very similar to the other circular movements we see, like AV nodal reentrant tachycardia or AV reentrant tachycardia. The difference here is both of these pathways, the fast and slow pathway, are both within the ventricle. It's possible to get other types of ventricular tachycardia where there's just an abnormal or irritable focus in the ventricle and it's just firing off impulses very quickly. But that's a little bit less common.
Interesting. Okay. So we have our patient now. We have this patient called maybe for some chest discomfort, and you hook them up to the EKG. They're awake talking to you, and suddenly you see this wide complex tachycardia that's at 170 beats per minute. How do you approach this?
So the first thing I teach people is we want to filter out the mimics, right? Because if we start to go down the road of treating this everything like ventricular tachycardia, there's only a few bad things that we're going to miss. So let's consider those up front. The mimics that I'm most concerned with, one, are sodium channel blockade, like we talked about, maybe a TCA, a Benadryl overdose, or any other number of medications that cause sodium channel blockade. That, not only does that typically cause a tachycardia, but it can cause widening of the QRS. So that can give us a wide complex tachycardia. Two, as I mentioned before, severe hyperkalemia has the same effect as sodium channel blockade on these ventricular cells. So severe hyperkalemia can cause a wide complex, and if there's a coexisting morbidity that's causing the patient to be tachycardic, that will cause a wide complex tachycardia. The third, sometimes you can get a massive MI, a massive STEMI, and the degree of ST elevation actually fuses the QRS and the T wave together on the ECG so that it looks just like one big monomorphic blob. You don't see a QRS complex, you don't see a T wave. You just see this big tombstone that's the fused QRS and T wave in a STEMI. If that person also has tachycardia, these big funny looking tombstones or shark fins can get pretty close together and can give the appearance of a wide complex tachycardia. Now, the QRS complex may not actually be wide, but in number of leads, you might not be able to distinguish the QRS complex from the QRS-ST-T complex. And so that's one that I like to consider as well. The reason why these three things are important to filter out It's because they all need specific treatment, they're all life-threatening, and none of them are going to respond to the types of treatment that we're going to use for other tachydysrhythmias. Because I think it's important to consider this up front, and because I say you need to filter these out, I have a mnemonic. It's an acronym SPAM filter. So the S stands for sodium channel blockade, the P stands for potassium, and the M stands for MI. It should only take you a few seconds to glance at the EKG and convince yourself, okay, I'm not dealing with sodium channel blocker toxicity, hyperkalemia, or a massive MI.
With regards to the sodium channel blockade and the hyperkalemia, are you ruling these out based mainly on the history, or are there some EKG findings that are going to help you rule these out as well?
So both. History and EKG findings are both going to be important. As far as sodium channel blockade, there's a few hallmarks of an EKG and sodium channel blocker toxicity. Typically, these patients are tachycardic, wide QRS, prolonged QT, and they often have a tall terminal R wave in AVR that goes along with some right axis deviation. So that combination of that widening QRS with a long QT, right axis deviation, and then the patient's history. Did they have access to medications, sodium channel blocking medications? Is there concern for any kind of self-harm attempt? Psychiatric history? Are they altered, right? What are they complaining of? Those are the things that are going to go into a sodium channel blockade for me. Typically, that's not going to have as wide a QRS. A lot of VTAC is going to be kind of 140 milliseconds or longer. The QRS widening in a sodium channel blocker toxicity is usually going to be like 110 to 140. So it's a lot of it comes down to pattern recognition, but you're definitely going to want to keep the patient's history in mind.
Okay, and the drugs you're looking, or the ingestions you may be looking for on your history there are going to be your TCA overdoses or maybe a cocaine overdose, kind of your big ones, and then your treatment is going to be with sodium bicarbolysis.
Correct.
Okay, what about hyperkalemia?
Hyperkalemia, so some of the classic signs we know about are peaked T waves. Those are classically described as being an earlier finding and are not necessarily associated with severe hyperkalemia, but you're going to look for peaked T waves. You're going to look for that broadening of the QRS. If it looks bizarre, a lot of times you start to get these kind of slurred changes between the end of the QRS and the start of the T wave. Obviously when hyperkalemia gets really severe, it starts to just degrade into what looks like a sinusoidal pattern. But these kind of bizarre, very peaked T waves, again, especially in conjunction with the patient history, end-stage renal disease, obviously being a concern. Also, patients in DKA oftentimes have that combination of hyper-K, but also tachycardia from the underlying DKA. So I feel like those are the patients in which I see the really wide complex tachycardia due to hyperkalemia.
If you're in a system that has a choice between gluconate and chloride, do you have a preference there?
So calcium chloride is a lot more sclerosing and irritating on peripheral veins. There is relatively little advantage to it. There's some teaching that maybe, and this is maybe beyond the scope of this lecture, there's some teaching that maybe the calcium gluconate has to go through metabolism through the liver before it's effective. I don't even know if that's totally true. If you have a great, solid, large bore peripheral IV, and you had the option to give calcium chloride, that would be okay. But if there's ever any doubt, just give the calcium gluconate. The dosage is a little different, usually a gram of calcium chloride versus 2 to 3 grams of calcium gluconate. But yeah, mostly in our department, we're using calcium gluconate.
And then can we talk a little bit about this, the last one in your SPAM filter, the myocardial infarction? Can you tell us a little more nuance about maybe some history findings that might help steer you? Because some of these patients will present with some chest discomfort, so maybe some ACS symptoms, but the origin and what we're concerned about is different, it sounds like.
Yeah, absolutely. There's not going to be a huge degree of difference in the symptoms or the presentation of a patient, for example, who's in VTAC versus who's having a STEMI. The thing that's going to distinguish those, there's a few elements on the ECG that you can look at. The first is the rate. It's generally uncommon for STEMIs to present with tachycardia in the first place, at least severe tachycardia. It happens, but most of the time these patients have normal heart rates. So when you see what I'm calling to be a wide complex tachycardia mimic, because the ST segment is fusing the QRS and the T wave. A lot of times those patients are going to be in the 100 to 110 range for rate, as opposed to like VTAC, we said it's going to typically be over 120. So the rate's usually a little slower. Second of all, because these apparently wide QRS complexes are actually the QRS and the T wave, the baseline is essentially flat in between them. You've got your QRS and your T wave all fused together in this one big tombstone, and then you have basically a flat ST segment before the next one. As opposed to VTAC, where you're kind of having this up and down because you have QRS complexes and T waves. The last thing I would say is you want to examine every lead. You know, this is something that could fool anybody on a single lead monitor. But on a 12-lead ECG, some of those leads should demonstrate that, oh no, the QRS actually isn't wide. I can see the QRS in this one lead is a normal narrow QRS followed by a T wave. So what I'm seeing in the rest of these leads is actually this fused ST segment that's fusing the QRS and the T wave. A lot of times they call them lambda waves or shark fin waves. When you get a massive MI like this, a lot of these complexes, they look like big shark fins. And they should be in a distribution that's consistent with a STEMI. Right? So if you have an LAD occlusion, yeah, you should expect to see those big positive shark waves in one and AVL and the anterior precordial leads. You should also expect to see maybe some reciprocal depression, like inverted shark fin waves in the inferior leads.
This is probably a good time to interject. It can be so hard to describe these EKGs on an audio medium. We're going to have examples of all of these that we talk about today on our show notes. So go down to the notes section at the bottom of your audio app and click on our show notes, and you can see examples of all these EKGs we're talking about today. So what's next? We've gone through our spam filter. We've considered all of the alternative mimics, and we've decided we don't think it's any of those. How do we proceed now?
So the next thing I'm going to say, now we're going to go regular or irregular. And I specifically put the spam filter first because those same things in the spam filter, sodium channel blockade, hyperkalemia, and MI, those can happen in AFib, right? So those can be irregular as well. We still want to filter those out first. But now we're through those, we're going to look for irregular versus regular. And this really is just like it sounds. You're going to look at how the QRS complexes march out. Are they happening with exactly repeating intervals? Or is there a variation in those intervals over time?
Question. The street trick here is to take another piece of paper, hold it up to your EKG or your rhythm strip, make marks with your pen, and then move it down. Is that going to be enough accuracy for this?
Absolutely. That's a great way to do it. Personally, I'm a huge nerd and I carry a pair of calipers with me all the time, but I know that most people don't do that. And we all have enough stuff hanging off of us at any given time, so I'm not going to tell you that you have to go out and buy a pair of calipers. The paper marking trick is what 95% of my colleagues do. It works great. One trick I would add to that, if you're really struggling with something that seems regular but might be a little bit irregular, instead of just marking out one RR interval, mark out 2 or 3, and then see if those line up. Because then you're kind of accumulating some of the irregularity, and you might pick up some irregularity that you don't see on a single, beat-to-beat basis.
Yeah, and I would even throw in there, print yourself out a good chunk of time to look at, because, if you just do a short duration of time, there could maybe be some anomalies, some ectopic beats or something. Does that sound fair with what you're saying?
Absolutely. And I would add that, rate-controlled AFib is usually pretty obviously irregular. But the faster that rate gets, and the reason for this is because with normal AFib, what's dictating the ventricular rate is essentially the refractory period of the AV node. And so as the rate gets faster and faster, you're really relying just on the refractory period of the AV node, and the QRS complex start to become more regular. So basically all I'm saying is that with really rapid AFib, the irregularity becomes less obvious. And so just like you're saying, measure them out, mark them out on a piece of paper, make sure you have a longer rhythm strip. When we're talking about irregular, it can be subtle, that irregularity, but most of the other arrhythmias that we're talking about, the regular arrhythmias, they are really stone cold regular.
And so what are we thinking about? We see this irregularity. Why is it important to look for that? What does that make us think? How does that change how we proceed?
So 95% of the time or more, an irregular wide complex tachycardia is going to be atrial fibrillation with either a left bundle branch block or a right bundle branch block. And that is managed just the same as atrial fibrillation. There are two important considerations, though, in the irregular wide complex tachycardia. The first is torsade. Now, this is unlikely to be tricky for a couple reasons. First of all, patients that are persistently in torsade are usually either in arrest or peri-arrest. It's not a rhythm that people tolerate well. More commonly, people with torsade are having kind of paroxysms of it. They're going into it for a few seconds and then back out and then back into it. Still very dangerous, still needs to be managed, but it's unlikely to be a mimic of, say, AFib with a bundle branch block. The more important one that we need to identify in a wide complex irregular tachycardia is atrial fibrillation with pre-excitation, or AFib with WPW. We talked a little bit about WPW before, right? This is when you have a bridge of tissue that's coming from the atria to the ventricles, not through the AV node. So if the atria are fibrillating, any of those impulses can get dumped right into that abnormal bridge and dumped directly into the ventricles. And there's very little limit in how quickly the ventricles can respond to that. Compare that to AFib that's coming through the AV node with a rapid ventricular response. Yeah, the ventricles can get going pretty fast, but ultimately the ventricular rate is going to be limited by the refractory period of the AV node, because the AV node acts as a gatekeeper to the ventricles to make sure they're not getting hit too fast with those impulses from the atria. If you have this abnormal tissue bundle in WPW, we don't know what rules it's playing by. Certainly not the rules of the AV node. So it could end up conducting those impulses really fast to the ventricle. And if they get going too fast, it overcomes what the ventricle can manage and you've got VFib.
Can you ever really be certain that it's not pre-excitation? Like we don't think it's torsades. We think it's some sort of AFib because it's irregular. Can you ever be certain that there's not a pre-excitation?
Maybe not 100% certain, but if you're looking at an EKG, you have an irregular rhythm with wide complexes. Those complexes are consistent with either a right bundle branch block or a left bundle branch block. You have an overall rate of under 200. Every QRS looks the same as every other QRS. And that patient's looking pretty stable. That is highly unlikely to be a pre-excited AFib.
Okay. And so torsades we're going to treat with cardioversion, MAG, as we know. And you said we're going to treat AFib with RVR like any other AFib with RVR. There are special considerations with medications when we see a wide complex here.
So the big concern is if it is AFib with WPW, then there are some very important considerations in how we treat that. The guiding principle is that we can't block the AV node. Even though these impulses are coming down through this accessory pathway, the AV node is still there and it's still doing some work by conducting some impulses normally, and its refractory period is slowing down how many of these impulses are getting to the ventricles. So if we take out the AV node, we're essentially taking out the only thing that's putting some brakes on the ventricles. So in AFib with WPW, we need to avoid any medications that might block the AV node. So obviously that's beta blockers, calcium channel blockers. Also, though, amiodarone has AV nodal blocking effect. So we need to avoid all of those medications.
So what is the medication we fall back on then?
The only safe medication in AFib with WPW would be procainamide. But honestly, if you're worried that you're dealing with AFib with WPW, regardless of patient stability, I'm going to shock that patient every time.
What could happen if they're given adenosine?
If they're given adenosine, oh yeah, I should have mentioned adenosine along with beta blockers, calcium channel blockers. Adenosine completely blocks the AV node, and it only does so for a few seconds. But if we take out the AV node completely for a few seconds, we are leaving all of the conduction to the ventricles through this accessory abnormal pathway from the atria to the ventricle. We have no idea what the characteristics of that pathway are and how fast it can conduct. If that pathway starts conducting every fibrillatory beat from the atria to the ventricles, and there's nothing coming through the AV node to cause the ventricles to have a refractory period and put the brakes on it, there's no limit to how fast the ventricles are going to start beating, and you're going to go into fib.
And that's kind of the feared consequence here of blocking that AV node, is we can decompensate into a more lethal rhythm like VFib.
That is the reason why we really need to make sure we're identifying this rhythm and be thoughtful about our treatment. And that's why this comes next in the step after the spam filter, is rule out irregularity, because we need to be very cautious how we would treat a patient in AFib with WPW.
Okay, so we're starting to move down our stepwise approach here. We're first going to consider mimics, spam, because we're going to treat those differently. Next, we're going to consider irregularity, because some of our treatments can be dangerous if there is irregularity, and there's specific treatments here as well. Let's say neither of those are true. It's a regular, wide complex tachycardia. What do we do now? How do we proceed?
So this is like the $1,000,000 question here, right? We've gotten to the point where we can ask, is this ventricular tachycardia or is this SVT with aberrancy? For the purpose of this lecture, when I say SVT, I mean any tachycardia that originates above the AV node. So that can be sinus tachycardia, that can be an ectopic atrial tachycardia, a junctional tachycardia, that can be an AV nodal reentrant tachycardia. Anything that depends upon tissue at or above the AV node for its initiation and propagation, we're going to call an SVT. If that SVT is being conducted to the ventricles through a bundle branch block, that resulting tachycardia is going to have a wide QRS complex. And that's, at this point, what we want to distinguish from ventricular tachycardia. So this is something, there are dozens of criteria that have been developed to help differentiate on a 12-lead ECG between SVT with aberrancy and ventricular tachycardia. Some of those are well studied and well known and recognized. Some of them are very obscure, but none of them are perfect. I think the ones that people have most heard of are the Brugada criteria. Some people have heard of the Verikai criteria, the ABCD score, or more recently there's something called the Basel criteria. Again, these have all been studied, established. They all have some degree of performance that is not perfect. Some of them take a really long time to apply, like the Brugada criteria. Even someone who's fairly expert applying the Brugada criteria has been shown to take about 90 seconds, which violates my rule up top that you should really only need to look at the ECG for about 30 seconds before you know how you're going to treat. They're really complicated. It's really hard to access that type of detailed memory in a stressful situation, especially if you're in an ambulance and you're the only provider for that patient and you're trying to do everything else. You're trying to start an IV, checking vitals, right? You're not going to be able to access the Brugada criteria no matter how well you practice it and do it perfectly. And even if you do, it's going to take you too long, and the result you get is not going to be 100% perfect.
So I love this. Okay, so let's start. What's the physiology then that is kind of going to inform what our approach is going to be then?
If you're going to use a process to try and distinguish between SVT with aberrancy and ventricular tachycardia, I don't want it to be based on rules that you are just memorizing, rote memorization, because it takes you away from understanding what's going on. So I propose we come up with a separate set of rules that's going to be based on some physiologic principles that we can understand. The first of which is that if this is an SVT with aberrancy, by definition, it's originating from above the AV node. So if something's coming from above the AV node, first of all, if it's a sinus tachycardia, we should see some P waves before the QRS complexes. So that's one thing that we can look for. Second of all, if it's coming from above the AV node and it's still wide, well, that means that there's some kind of interruption in the conduction, because it's got to be coming through the AV node through those conduction fibers. So the only reason why the QRS would be wide in that case is because you have a left bundle branch block or right bundle branch block. That's as opposed to ventricular tachycardia, where it's originating in the ventricles. It can really have any shape that it wants. It's not limited to those conduction deficits like a supraventricular tachycardia is. I also want to point out, before you dive into this, that once we've eliminated our spam filter and sinus tachycardia, which we'll talk about a little bit more in this approach, if you have a wide complex tachycardia, there's somewhere between an 80 and 90% chance that that's ventricular tachycardia. If the patient has a history of heart disease or heart failure, previous MI, previous episodes of ventricular tachycardia, it's closer to that 90%. So spending a lot of time with a rule that might only be 90% accurate on a rhythm that you're already 90% sure of, it's not a great use of your time.
Yeah, I love that back to the, you can even almost put that in the spam filter, right? Because like The spam filter you're talking about is a lot of great history questions that you can hit rapid fire, and just throwing in there the previous episodes of ventricular tachycardia, previous MI or heart disease, get those questions out there right away, right off the bat.
Absolutely. Those historical elements should really change the way that you think about this presenting patient.
Yeah. So how are we going to use this physiology then that the supraventricular tachycardias are going to follow a certain rhythm or certain look to them, and the ventricular tachycardias are going to be highly associated with prior MIs? How are we going to use this understanding to now inform our approach moving forward?
Again, I want this to be an approach that is based on your understanding of the underlying physiology of the heart, so you don't have to just purely memorize it. The first and easiest thing that you have to check for is P waves. If you can see a P wave before every QRS, that's not ventricular tachycardia, even if that QRS is wide. A P wave before every QRS that looks like it's getting conducted, well, that means it's coming from above the ventricles. I would say, honestly, after spam filter and checking for irregularity, checking for P waves is the last thing you need to do before you said, okay, I'm going to turn this podcast off and treat everything else like VT. I think once you get to that point, once you've ruled out spam filter, irregularity, and sinus tachycardia, you're okay to treat everything else like VTAC if you want. But if you want to listen a little longer, we'll talk about some more elements that you can look for. After P waves, I think of 4 elements of the ECG that we can look at. And I've created another mnemonic, ABCD. All right? I should point out that there's an established VT score that uses an ABCD approach. This is different. Sorry for the confusion. But this is just 4 simple elements. We're going to talk about each one, and we're going to talk about how they relate to your understanding of the heart works, so that you don't just have to memorize these. So the A stands for axis. If you imagine a normal beat originating in the sinus node, coming down through the AV node, the bundle of His, and then the Purkinje fibers. It's starting towards the upper right part of your body, and then it's moving down to the lower left, because that's the orientation of the heart. You can have some alterations in that axis, but generally speaking, that should be the overall direction of depolarization of the heart. If you have an axis that's pointing in the exact opposite direction, in other words, if you have an overall QRS axis that's pointing down from the apex of the heart back up towards the right shoulder, really the only way for that to happen is because that impulse is originating in the tip of the heart, and that's all ventricular myocardium. So what we call an extreme northwest axis, this is more than negative 90 degrees. So it's extreme axis deviation. You sometimes see this because the QRS in AVR, which normally has at least some negative component, in an extreme northwest axis deviation, a lot of times the QRS in AVR is completely upright. There's no negative component of it. That's a pretty good indication that it's starting down in the ventricles and moving backwards from the normal direction of an impulse propagating through the heart. So I would say first thing, look at the axis and glance at AVR. You're looking for a totally monomorphic upright QRS in AVR or an extreme axis deviation, both of those being indicators that you're dealing with ventricular tachycardia. The next one is B. That stands for bundle branch block. So like I talked about before, if you have an impulse that's an SVT, whether it's sinus tachycardia, a flutter, PSVT, whatever. If you have an impulse that's starting above the AV node and still resulting in a wide QRS, that's almost always because there's either a right bundle branch block or a left bundle branch block. So look at your QRS complexes. Do they look like a classic bundle branch block pattern? Now, a lot of these criteria, these kind of more formal established criteria, they've got 100 rules about what exactly makes something a typical versus an atypical bundle branch block pattern. If you want to memorize those rules, that's fine. But I would say it's okay in a pinch to just look at them and say, does that look like a right bundle branch block? Does that look like a left bundle branch block? Generally speaking, you're going to be looking at leads V1, 1, and V6. So V1 and then the lateral leads. Just to see, does this look like a normal bundle branch block pattern? If it looks completely different from any bundle branch block pattern, that makes it a lot less likely that that's a abnormally conducted signal that's starting above the AV node. So if you see some QRS complexes that don't look like a classic bundle branch block pattern, that's going to lead me to think VTAC. The third element is something called concordance. So concordance, this is our C. Concordance just refers to all of the QRS complexes in the precordial leads, V1 through V6. Are they all completely upright? Or are they all completely down? That's abnormal. Again, you're thinking about a signal or an impulse that's coming from the upper part of the heart through the conduction fibers down in the ventricles. There should be some balance as that's being delivered to the ventricles, even if there's a bundle branch block. There should be some balance in how that's being delivered to the ventricles as you move around the patient's chest wall. So some of those should be upright, some of them should be down. If all of the QRSs, V1 through V6, are all going straight down, that tells me that that signal is actually originating in the anterior wall of the heart, which is ventricle. If they're all totally upright, that tells me it's originating in the posterior wall of the heart. That's all ventricle too. So we're going to quick glance. It takes 2 seconds to look, less than 2 seconds, to look at the precordial leads and say, are these all totally upright or all totally down? And if that's the case, that's VTAC. The last thing in our ABCD is duration. So a right bundle branch block and a left bundle branch block, yeah, they're wide, but they still benefit from those rapid conduction fibers. They're still coming from the AV node down into the ventricles through either a functioning right bundle or left bundle. And so the initial part of the depolarization still happens pretty quickly. It's the second half where that needs to propagate slowly across the half of the heart that doesn't have the benefit of those fibers. That's the part that gets drawn out and wide. If something's originating in the ventricle, it doesn't get any benefit from those rapid conduction fibers. It's got to use myocyte to myocyte conduction the entire time. So first of all, the initial part of the depolarization usually looks a little slower, as opposed to a bundle branch block where the initial point or the initial portion of the depolarization usually happens pretty quickly. Second of all, the overall QRS duration tends to be a little bit wider in ventricular tachycardia. And I'm just going to pick a number, 160 milliseconds. So when your QRS complexes start to get over 160, that's going to make me think VTAC as opposed to SVT with aberrancy.
Okay, so to kind of summarize this and put it all together, we're going to start with our spam filter, look at our mimics, make sure that none of those are going on. Then we're going to look for any irregularity, determine if this could be AFib with pre-excitation or polymorphic VTAC or Torsades. And then we're going to look for P waves. And if any of those three things are true, we're going to treat this differently. It's not VTAC. If all of those three things are untrue, if you want, safest thing to do, you can stop here and just treat them all like VTAC. That'll be safe. That's a safe approach to that patient. But if you go deeper and you want to be extra sure, you can go through your ABCD approach. A, starting with access. If you have a monomorphic positive QRS in AVR, that's going to tell you it's VTAC. If you lack your typical bundle branch block morphology, that's going to be VTAC. If your precordial leads are all concordant, going the same direction as each other, that's VTAC. If the duration is greater than 160 milliseconds, that's VTAC. What if all of these things are untrue?
If all of these things are untrue, it does not mean that it's not ventricular tachycardia. Everything can be ventricular tachycardia, especially once we've gotten through spam filter, irregularity, and looking for P waves. You will never know that it's not ventricular tachycardia. That being said, if all of those things are untrue, you don't have any compelling evidence that you're not dealing with an SVT with aberrancy. Obviously, if you have an old ECG for this patient, this is something we often have the benefit of in the ED. Rarely do you have the benefit of this in the ambulance. But if you have some history of this patient or an old ECG and you can see the morphologies of their QRS that this is definitively an old right bundle or an old left bundle, that's also something that can suggest to you that this might be SVT with aberrancy.
Yeah, I really like your approach and I like all this. As I'm going through this, I'm thinking about how we treat this in the pre-hospital setting, and we're pretty limited to electricity and certain meds. A lot of services, all services will usually have mag, bicarb, calcium, amiodarone, and adenosine. Some other systems do have things like diltiazem and lidocaine. And then there are fewer systems that have maybe beta blockers or procainamide. So what's a reasonable approach for EMS with regards to these patients?
So let's start with what not to do. Never give a beta blocker or a calcium channel blocker to a patient when ventricular tachycardia is on the differential. So even if you've gotten through, you said, I'm going to do the ABCD. You get through the ABCD. You think, this really seems like SVT with aberrancy. You can't rule out VTAC. You're never going to give a beta blocker or a calcium channel blocker. Say you want to treat it as VT. Well, based on the medications you just described to me, you could give them amiodarone, treat it as VT. If they have SVT with aberrancy and you give them some amiodarone, no harm done. You can also cardiovert this patient. If they're totally stable, then yeah, you got a short drive to the ED. You might wait, let them see what they want to do. If you have a longer transport time, if they're quasi-stable, or certainly if they're looking unstable under any circumstance, you obviously want to cardiovert them immediately. One medication you mentioned was adenosine. It probably depends. I'm sure you have to be familiar with your medical directive for your system, but there is good evidence that adenosine is safe in a stable, regular, wide complex tachycardia. If you give adenosine to a patient in stable VTAC, it doesn't do anything. The ventricles are tacking, they don't care what the AV node does. You turn the AV node off for 10 seconds, doesn't make a difference. No harm, no foul. If you give adenosine to SVT with aberrancy, and it's an AV nodal reentrant tachycardia or an AV reentrant tachycardia, it'll convert that rhythm. So giving adenosine to a stable, wide complex tachycardia is safe. It can be very helpful diagnostically. It's usually the first thing that we do in the emergency department when a patient comes in with that rhythm. Again, your particular medical system may have directives about that and about whether they want you to do that. But in my opinion, that's a safe medication that's very effective diagnostically.
I want to highlight this because I think this is important, just the safety and unsafety of each of these. And so with regards to an irregular tachycardia, well, first and foremost, electricity, pretty much safe for all arrhythmias. But with regards to a irregular tachycardia, if we're thinking about medications, unsafe medications are going to be our calcium channel blockers, our beta blockers, and any AV nodal blocker such as adenosine or amiodarone are going to be unsafe in an irregular wide complex tachycardia. Now, in the setting of a regular wide complex tachycardia, beta blockers, calcium channel blockers, still unsafe. But at this point, we may consider trying amiodarone or maybe diagnostically adenosine.
Correct. And this is why that distinction between regular and irregular is so critical. Because once you've made that distinction, even if you can't perfectly identify the rhythm, you have established which medications are safe and unsafe to give. So yes, once you've ruled out irregularity, and you know that you have a regular wide complex tachycardia, then yeah, adenosine, amiodarone, they function very differently, but they're both safe and appropriate to try in that situation.
Are there any special considerations for the pre-hospital provider? Or in other words, like if you were to say the most important thing to remember, if you remember nothing else?
So if you remember nothing else, I would reiterate. I would love for you to go through your spam filter irregularity and look for P waves, but after that, totally fine to treat everything like ventricular tachycardia. The other thing I would reiterate, something that you just said, electricity is great. Electricity is safe. It has no side effects. It is typically effective. So yeah, it's always fine to reach for electricity once you feel like you may be dealing with ventricular tachycardia.
Can I pause you there for one moment? There are two kind of protocol pitfalls that I think a lot of pre-hospital providers fall into in the realm of cardioversion. The first is the energy selection. Now, sometimes that's completely dictated by your protocol and you don't really have a choice at what you should be starting at. But if you do have a choice, do you have any guidance on the energy selection?
So you may get different opinions on this. My feeling is if this patient is concerning enough that I want to shock them, I want the best possible chance that I'm going to get them out of it. So I'm going to go straight to 200 joules biphasic when I'm doing a synchronized cardioversion.
Nice. I like that. And the second question I have is, you know, a lot of pre-hospital protocols have something in there about providing a little bit of sedation to the patient to make the procedure more comfortable. But then some people get in this sort of mental feedback loop, almost stalled out cognitively, because, usually what's available is something like midazolam, and then they get worried about that affecting someone's blood pressure, and they're already tenuous and unstable. So my thinking as a pre-hospital provider has been, if I need to forego something like midazolam and cardiovert them, that's actually what's helping them. It's going to, yes, be unpleasant, but I need to deliver the electricity. What do you think about that mindset?
So I have had the interesting experience of doing 2 synchronized cardioversions on completely stable and completely unanesthetized patients for reasons that we could discuss another day. But in my N of 2, I learned a little something. This was done with patient consent, so don't be too concerned. I've learned a little something. One is that the discomfort of a synchronized cardioversion is instantaneous. There is no residual pain after it. It is a very, very short, although very uncomfortable experience. The pain doesn't last after the delivery of the shock. The more uncomfortable part of a cardioversion is the anticipation and the anxiety around it. So if you have to do a cardioversion and you're not doing a complete sedation, I would focus on anxiolysis. So, for example, a small amount of Versed. But just like you said, the worst thing in the world is a patient dying. It is not a patient being uncomfortable from a momentary shock. So yes, the right thing to do for your patient is a little bit of anxiolysis before this, but when in doubt, shock them.
Yeah, and I think the other thing to remember too, that I didn't realize the very first time I synchronized cardioverted somebody on the ambulance, is even if you give them that midazolam, which is important for the anxiolysis as you prepare for the procedure, they still feel it. It doesn't stop them from feeling the pain. What it does do is provide some amnesia. And so most patients will not remember that shock after you've delivered it, but realize that when you do shock them, they're still going to cry out. It's still going to be painful for that instantaneous moment.
The other bit of advice I would give on this very niche topic, if I were to do this and you have multiple people there, I actually counsel them that I am not going to do the countdown before the cardioversion, because then you're just adding to that patient's anticipation of what's going to happen. So yes, make sure any other people are clear and that they know what you're doing, but if possible, maybe skip the countdown to when we're going to hit you with 200 joules, because that just makes things less pleasant.
All right, we're starting at 30, 29, 28, 27.
Is there anything that we're going to do differently in the ED, or additional tests that we may do that might help us?
One thing I would tell you, I think a common mantra is, the first thing they do in the ED should have been the last thing you did in the ambulance. Or for the ED, the first thing that the cardiologist does should have been the last thing that we did. The honest truth, patient shows up in a ED with a stable, wide complex tachycardia. A lot of times we're just calling cardiology, and we're going to wait and see what they say. Yeah, we're going to take precautions. We're going to have pads on them. We're going to have them on the monitor. We're going to have people in the room. This isn't a patient I'm forgetting about, but it's not the case that I am throwing treatment at this patient the second they roll into the ED every time. So if you have a stable patient with a short transport time and you think, I don't really want to do anything, I'm going to bring them to the ED and let them decide, that's completely fine, because a lot of times that's what we do. My first approach, if I weren't going to defer to a cardiologist, would be pretty similar to what I've described here today. If they're unstable or any concern for instability, I'm going to cardiovert them immediately. If they're stable with a regular wide complex tachycardia, I'm going to glance at the ECG and I'm going to look for the exact same things I just described. If I have time and availability, I'm going to check an old EKG to see if I have any evidence that maybe they have an underlying right or left bundle branch block or other conduction abnormality that accounts for their wide QRS. If I find something that looks to me like a slam dunk for ventricular tachycardia, I'm either going to initiate amiodarone or procainamide. I'm going to talk to cardiology or consider synchronized cardioversion. If I don't find anything that's convincing to me for ventricular tachycardia, I'm going to give a trial of adenosine, probably just once, and then I'm going to move on to treating it as ventricular tachycardia.
On that note, I think it's important, a lot of times, I've worked in systems where you started with the 12 milligrams, and then I've also worked places where you start with 6 and go to 12. If you have the option, this might be the time to do the 12, kind of like do it all the way, make sure it's going to work, and then you know for sure if it worked or not.
I think that makes a lot of sense because unlike SVT, where I have no problem sitting there and trying 2 or 3 increasing doses of adenosine to try and get their SVT to break, with a wide complex tachycardia, the whole point is I don't know for sure that it's SVT, right? And so just like you said, I'm using this diagnostically. The same way I want to give my first cardioversion the best chance of success, I want to give my first adenosine the first chance of success. There's no indication that you're going to cause harm to a patient in VTAC because you give them 12 milligrams of adenosine instead of 6 milligrams of adenosine. So let's give them a big dose and see what happens.
Well, this has been great. I think this is a phenomenal approach. I love the 30-second rule and keeping it simple and relying on the physiology. I'm going to connect it back to the principles you mentioned at the very beginning. Patient stability is key. So if the patient is unstable, you're shocking that patient. If the patient's stable, take 30 seconds to go through your spam filter, make sure you're not missing a mimic, look for irregularity, make sure that this is an AFib with pre-excitation, look for P waves, and if not, all else, treat as wide complex tachycardia. If you fall back on those principles, you'll be safe and you'll treat patients effectively. Anything else you want to leave us with?
No, I think that was a great summary. I would just say that whether it's wide complex tachycardia or any other arrhythmia, again, go out there and be prepared not just to treat VTAC, not just to treat a flutter, not just to treat SVT. Go out there and be ready to manage arrhythmias without knowing exactly what they are. Because if you're counting on knowing what everything is, you're going to end up uncomfortable and scared. If you have an approach that doesn't depend on knowing exactly what everything is, but that you know is safe, you're going to be ready to treat these patients much more effectively.
That's awesome. And I want to throw in there as well that mentality and everything we're talking about requires on you to be able to perform the fundamentals of EKG interpretation. You need to be able to identify the rhythm. You need to be able to look for P waves. You need to look for axis and bundle branch block. You need to be able to do these things. So use every opportunity that you look at an EKG on every patient to go through your stepwise approach and practice that great interpretation so that when you are faced with someone where you have some real decisions to make, you're not digging into the recesses of your brain trying to pull these fundamentals out from an unused part.